Welcome to Trauma and Orthopaedics for Medical Students lecture on the shoulder and elbow in the MLA lecture series. In the shoulder, we're going to look at some common injuries, shoulder dislocation, clavicle fractures and humeral fractures, and then we'll look at some of the more chronic problems, so rotator cuff disorders, frozen shoulder, some biceps problems, shoulder arthritis, and finally arthritis of the AC joint. As with all of the other lectures, we are mapping it to the MLA guidelines, and as you can see here, we're going to cover topics such as acute joint pain and swelling, soft tissue injury, trauma, arthritis and bursitis, amongst others. Starting with the shoulder, it has very unique anatomy. It's inherently unstable, and you have a very flat glenoid with a very round humeral head, and they are essentially incongruent. So stability is assisted by a number of structures which you don't see typically in other joints. These are the labrum, the capsule, the ligaments, the muscles, and to a large extent the neurology, particularly the axillary nerve. If we start with shoulder dislocation, look at the pathology. 90% of all dislocations are traumatic, particularly with movement into abduction, external rotation, such as falling on an outstretched arm. 90% of them are anterior, and classically the posterior dislocations are associated with fits, so epilepsy or electric shocks. But remember that more commonly epilepsy and shocks will give you an anterior dislocation, so just bear that in mind when you're answering questions on the subject. Patients present with a lot of pain. You get this squared appearance of the shoulder with prominence of the acromion. They're obviously very reluctant to move it. And as dislocation is quite common and recurrent dislocation is common, this may well have happened before, in which case they'll tell you what the diagnosis is. The examination is fairly straightforward. A lot of it is on the appearance. It's difficult to move very much, and you can palpate, but this may not help you very much. It is critical that you examine the neurovascular status, in particular the axillary nerve, as this can be injured either with dislocation or relocation, but you also need to have a look at the rest of the brachial plexus just to make sure they don't have a broader brachial plexus injury. Investigations are fairly straightforward. This takes the form of an X-ray with an AP and an axial or a lateral view to determine whether the dislocation is anterior or posterior. If it looks like there's a fracture or the injury is a posterior dislocation, then you really need to get a CT scan, but these are not necessary for standard anterior dislocations. As I mentioned, the posterior dislocations are less common and they can be missed. Clinically, the patient will have no external rotation at all, and on X-ray there may be this light bulb sign due to internal rotation of the shoulder, but it can be quite difficult to see, and the lateral can be very difficult to interpret. So a CT scan if you're not certain, and if there's any concern, then you definitely need a CT scan because there may be a fracture. The treatment of acute dislocations is pretty simple. They need reduction. There are a number of ways of doing this. The traction counter-traction is very safe. Analgesia will depend on your local policy, but they will need some analgesia. They may need muscle relaxant if they're big and it's been out for a while. After you've done it, you have to check and document the neurovascular status. Again, particularly the axillary nerve and sensation over the deltoid. And you have to get the X-rays in two planes again to confirm that you actually have reduced the shoulder. In recurrent instability, the patient doesn't present with a dislocation, they present with a history of repeated episodes. So they may describe it getting easier and easier to come out. They will tell you where they are apprehensive. When you do the clinical examination, you have to check the neurovascular status again, make sure they haven't got any damage to the axillary nerve. And there is this apprehension test where you put the arm into abduction, external rotation, crank the hand back and lever on the humeral head. The patient will tell you that it feels like it's going to come out. and this is very, very sensitive. The standard test is an MRI scan to have a look at the labrum and see if it's damaged, also to look at things like the Hill-Sachs lesion, which is a dent at the back of the humeral head that you get when the humeral head engages on the glenoid. The treatment of instability is really based on age, the number of dislocations, and patient preference. If they're young, under 20, then they are highly likely to have recurrent instability. If they have recurrent instability, so more than 2 episodes, or they have significant bone loss, then you probably should be heading towards some form of surgical stabilization. And you don't need to worry particularly about how this is done at the undergraduate level, but there's plenty of information about the different techniques that you can use out there. We'll move on next to another very common injury around the shoulder girdle, which is clavicle fractures. So the clavicle provides the only true attachment of the arm to the axial skeleton, and it's a long bone, it's a flat bone, and it fully ossifies in your 20s, so it's actually quite late to fully develop. The majority of clavicle fractures are mid-shaft, sustained by a fall onto the arm or the shoulder, and there's an axial load and something gives in the middle. They can be displaced or undisplaced, and they can be comminuted, so they may have multiple fragments or not. The presentation, like all fractures, is one of pain. There will be deformity at the fracture site. You have to check that it hasn't come through the skin at this point. They may feel tenting, and you may see tenting of the skin, and the arm will be dropped because it's no longer properly connected to the axial skeleton. The clinical examination, as I said, involves looking at the skin, looking at the deformity, and very importantly checking the neurovascular status, as again the brachial plexus is very close by. There's little to be gained from moving the arm around, because this is just going to cause pain. The investigations are very simple, which is an X-ray with an AP and some form of angled AP, because in theory you should get orthogonal views, but clearly you can't get that of the clavicle. But if you get a couple of views, it helps you identify the fracture a little bit easier. The treatment of acute injuries really depends on the severity, so how displaced it is, how much pain the patient's in, and what other nursing needs they might be. The first instance you give analgesia, and then a sling or a clavicle brace can be applied. The majority of clavicle fractures will unite, but it may take 2 or 3 months. Now, for a lot of people, they can cope. Some people need the arm back quicker. So you operate dependent on the patient and the fracture, and really individualizing the treatment. If the patient has significant acute problems, or if the fracture goes on to a non-union and it's symptomatic, then it can be treated with open reduction and internal fixation. So that's making an incision over the clavicle, lining up the fragments, and then fixing it with a plate and screws. It then unites within a couple of months, and the plate can be removed later if the patient wants it. But this is done in probably only about 10% of patients. We move on to the next fracture, which is humeral shaft fractures. So the humeral shaft clearly is vulnerable, as it's a long, thin bone, and you get, in the same way as the clavicle, you get the axial forces when you fall on an outstretched hand. It has some muscles you need to be aware of, so the biceps and the brachialis at the front with the coracobrachialis, and at the back you have the triceps. At the front you have the brachial artery and the brachial vein, and you have the musculocutaneous medial and ulnar nerves in the anterior compartment, with the radial nerve very closely applied to the bone in the posterior compartment. Again, like all the other fractures, the presentation is of pain and swelling. There may well be deformity. They're going to be very reluctant to move it, and they may have extremity weakness. Now you need to look at this and work out whether it is neurological. As we've mentioned, there are a number of nerves that go past the humerus, fairly closely applied, or whether it's simply pain related. The examination, like the examination of all fractures, you look at the skin to make sure this isn't an open fracture, and then you need to look at the nerves, as I've mentioned. So the radial nerve is responsible for wrist and thumb interphalangeal joint extension and sensation over the dorsum of the hand in the anatomical snuff box region. The median nerve is palmar adduction of the thumb and sensation over the tip of the index finger. The anterior interosseous branch of this is flexion of the thumb, IP, and index, DIP, the AOK sign. The ulnar nerve, you look at being able to cross the fingers or abduct the fingers against resistance, and sensation over the tip of the little finger. And with the vascular examination, you need to look at the radial pulse, the ulnar pulse, and look at capillary refill. So all these are fairly quick and simple things to do, and you do need to be aware of how to evaluate all of these major nerves and vessels. Investigations are fairly simple. It takes the form of an X-ray, both of an AP and, as I said before, you need an orthogonal view, which is a lateral, to see what the displacement is like in both planes. If there is any concern that this is close to a joint, you may need a CT scan, and if there's any worry about the nerves or blood vessels, then a CT angiogram is appropriate. The acute management, like all fractures, is very simple. You start with analgesia, and with the humerus, some form of splint. This is classically what's called a U-slab, which can go above or below the shoulder, depending on where the fracture is, and then it's placed in a sling. The idea of this is it provides a little bit of gravity traction to line the fracture up and provide some stabilization. It's very important that after you've done anything to the patient, you need to recheck the neurovascular status, and you should get an X-ray to make sure you haven't made things worse. The management of humeral shaft fracture can be either conservative or surgical. The conservative form is a lighter weight version of the humeral brace, which immobilizes the fracture. The downside of this is that the patient may have to be in this for up to 3 months. Surgically, if it's good for nursing of the patient, or a patient in which you think it's not going to unite because there's a lot of displacement, then surgical options may be appropriate, and this can take the form of an open reduction internal fixation with a plate and screws, or an intramedullary nail. And there are pros and cons to both of these that you don't need to worry about at the undergraduate level. If we now look at some of the soft tissue conditions that you see around the shoulder, we'll start with the rotator cuff. And a reminder of the anatomy, there are 4 muscles related to the rotator cuff, and these are the supraspinatus, the infraspinatus, the subscapularis, and teres minor. Over the top of these is a thing called the subacromial bursa, which lies between the rotator cuff and the acromion, and the rotator cuff, lateral humerus, and the deltoid. The primary function of the rotator cuff is to center the humeral head so that the deltoid can work. So those 4 muscles grab the humerus and pull it towards the scapula, so they're pulling the humeral head into the glenoid. When you initiate movement, those 4 muscles engage, and then the deltoid can pick up and rotate around that red dot in the middle, which is an axis of rotation. Typically, there are 3 things that can happen to the rotator cuff. You can get inflammation of the bursa, which is a bursitis. You can get catching of predominantly the supraspinatus under the acromion, which is called impingement. And you can get a rotator cuff tear, which most commonly is detachment of the supraspinatus insertion into the greater tuberosity. Frustratingly, all of these basically present in the same way. There is pain over the lateral aspect of the arm, which is worse on abduction, and patients describe this painful arc between about 80 and 120 degrees of abduction and sometimes flexion. They describe pain and catching when they put on a jacket or reach around to try and duck their bra, and commonly painful at night. If they have a rotator cuff tear and it's large, there may also be weakness, but sometimes the weakness comes from the associated pain. Clinical examination is notoriously unreliable. There's rarely any wasting that you can see because these muscles are quite deep, and there's very rarely any real tenderness that you can identify. They will have a full active range of motion. However, classically they will have this painful arc between about 80 and 120 degrees of abduction. There is a test called the Job's test, or the empty can test, where the arm is put out to the side, the thumb is turned down, patient pushes up and the examiner pushes down, and that reproduces the pain. But it is not terribly reliable. However, you should be aware of it as part of your examination. Investigation takes the form of an X-ray, just to exclude any unusual pathologies, and also things like calcific tendinitis, which we've not really mentioned. An ultrasound is a very useful way of picking up rotator cuff tears and bursitis. However, it's very operator dependent, and it's not diagnostic for a condition called impingement. The MRI, again, is very useful for getting a lot of detailed information about the rotator cuff and the rest of the shoulder. However, it is more expensive and takes more time to get. The treatment for all of these conditions in the first instance really is physiotherapy and possibly a steroid injection. If the patient is low demand and they have a rotator cuff tear, then this is certainly the way to go. If patients fail to respond to conservative treatment, then for impingement it is reasonable to consider what's called an arthroscopic subacromial decompression, where a little bit of the underside of the acromion is shaved away to make more room. If the rotator cuff is torn, then arthroscopic repair of the tendon back onto the greater tuberosity is the recommended treatment, and certainly works very well. However, it's dependent on the age of the patient, the size of the tear, and the quality of the tendon, and all of these factors have to be taken into account in the surgical decision making. The next common shoulder related condition is adhesive capsulitis, or frozen shoulder. In this condition, the capsule of the shoulder starts to get inflamed, contracts and thickens, as can be seen in the arthroscopic picture on the right. The vast majority, 90%, are idiopathic. 10% are related to trauma and diabetes, but generally speaking, we're not entirely sure why it happens. They go through a fairly predictable course, that for the first 6 months the shoulder is painful, just globally, and the range of motion slowly decreases. After about 6 months or so, the pain stops, and they then spend about a year just stiff, and as long as they stay within their range, it's relatively comfortable. It then typically loosens up over about the next 6 months, and they regain the range. So the average cycle is somewhere between 2 and 3 years for complete resolution. So patients present with a variety of symptoms. In the early phase, it's generally painful and the range slowly decreases. In the mid phase, it's stiff, particularly into external rotation. So in the picture there, you can see trying to rotate the arms out to the side, and they're just unable to do it. In the later phases, you may see that some elements are starting to recover, but typically patients present before this time. In the examination, you rarely see any wasting. There's rarely any tenderness, but if you get them in the early phase, the axilla may be a little bit uncomfortable. Typically, when they're properly stiff, they have 90 degrees of active flexion, about half that much abduction, no external rotation, and they can reach behind the back, typically to about the buttock or the belt. And importantly, the passive range is the same as the active range, but it doesn't hurt once they're over the painful first 6 months. There are no clever or provocative tests that you can do for frozen shoulder. Most of the time, the investigations are fairly simple. It's all given to you on the history, and an X-ray is taken to exclude odd pathologies such as arthritis, which will give you a stiff, painful joint, and occasionally you get bone tumours or other odd things, but these are pretty rare. If the story doesn't quite line up and you're not sure about the diagnosis, then an MRI will show a capsulitis very nicely, but it's obviously expensive to do and isn't really needed in most cases. As far as treatment is concerned, the vast majority will get better in a couple of years. So for a lot of people, you can leave it alone and reassure them that it will resolve. If they can't cope with that for work or social reasons, or it's not getting better, then the simplest treatment is a hydrodilatation where local anaesthetic, saline and steroid are injected into the joint itself. This distends the capsule and seems to kickstart a healing process, and typically about 75% of patients will get better with this. If they don't get better, then another option is a manipulation under anaesthetic, which is exactly what it says. Patient is sent to sleep, the shoulder is manipulated, and that usually regains the range, and then occasionally you can proceed to an arthroscopic capsular release, but this is fortunately quite rarely done. Next, we move on to problems related to the biceps tendon. So anatomically, the long head of biceps runs from the top of the glenoid down through the bicipital groove at the front of the shoulder to join with the short head of biceps, which comes from the coracoid. The long head of biceps slides up and down in this groove as you flex the shoulder. It doesn't move with elbow flexion. So the tendon can get snagged and rub in the groove and can become inflamed, and ultimately it can get worn and can rupture, and these are the two pathologies that we see. If the patient has tendinitis, they will describe pain in that groove, particularly as they lift the arm and flex the elbow at the same time. If it goes on to a rupture, they'll describe quite often preceding pain. The pain then goes away very acutely, and they get this funny lump halfway down the biceps, which is known as a Popeye sign. The clinical examination for tendinitis is relatively simple, and the patient will be tender in the bicipital groove, although this can be difficult to find in more well-muscled or well-padded patients. There is pain on elevation of the shoulder. However, the shoulder will have a full range of motion, and in theory there is a test called Speed's test to provoke pain in the biceps. However, this has been shown to be no more than 50-50 at best, so you might as well toss a coin. If the biceps has ruptured, there's often no pain, and on clinical inspection you will see the Popeye sign. If they actively flex the biceps, the Popeye will get worse, the bulge will get worse, and again the shoulder will have a full range of motion. The investigation of choice for both the biceps inflammation and the biceps rupture is an ultrasound. This will demonstrate the presence or absence of the tendon in the bicipital groove and will show the presence of tendinitis. It will also enable the operator to have a look at the rest of the rotator cuff, as often it's the same demographic of patient who present with biceps pain as present with rotator cuff problems. The conservative treatment of tendinitis is very simply analgesia, activity modification, and quite often that's things like weightlifting. You need them to avoid them for a while, to rest it, allow things to recover. And it is possible to do a steroid injection under ultrasound guidance up and down the bicipital groove, and this can relieve all the symptoms. If the biceps has ruptured, usually you ignore it. There is a 10% reduction in supination strength, which most people don't notice, and usually it's painless, it's only cosmetic. Occasionally, if people are manual labourers, then we repair it for strength, and sometimes people get cramping around the brachialis and the biceps, in which case we can look at treating it. The surgical treatment is reserved for patients with tendinitis whose symptoms don't resolve, or patients, as I described before, where the ruptured tendon is painful. And what we do here is a tenodesis of the biceps, which is typically done either arthroscopically or with a small incision. And the biceps is fixed to the anterior humerus, typically just at the bottom end of the groove. And at the same time, it's cut from its insertion into the glenoid. So it's an arthroscopic tenotomy and a tenodesis. This restores the cosmesis and gets rid of the symptoms very effectively. The next condition in the shoulder is arthritis. So the pathology of arthritis in the shoulder is basically the same as all other conditions, which is osteoarthritis, inflammatory arthritis, and post-traumatic arthritis. The presentation of all of these is the same. There's pain in and around the joint. It's often difficult to localize very well. There is a reduced range of motion, which can be very similar to frozen shoulder, which is why you always get an X-ray for frozen shoulder. There is often crepitus as the joint moves, and very typically patients complain of pain at night. On examination, like the rest of the shoulder examinations, there's very rarely any wasting, and usually there's no tenderness. The active range is very variable, but classically they lose external rotation quite early, even if flexion and abduction are relatively well preserved. The passive range is usually slightly more than the active, with pain that is deep in the joint and crepitus, neither of which you get when you examine for a frozen shoulder. And as with many things in the shoulder, there are no really good provocative tests to reproduce the symptoms. Investigation very simply is X-ray, which is the gold standard. This will confirm the presence of osteophytes, cysts, loss of joint space, etc. The treatment of shoulder arthritis is exactly the same as arthritis in all other joints, which starts with conservative management, which is analgesia, activity modification, physiotherapy, and sometimes a steroid injection, although these really don't normally have much of a lasting effect. Surgically, there is really only one option, which is to replace the shoulder. Occasionally, arthroscopic debridement is done in younger patients, but this is quite rare. Shoulder replacements typically have the same results as hip replacements. They last about 15 years. They're very good at getting rid of pain, but the range of motion that you get is very dependent on the individual and how stiff the shoulder was before the surgery. The final condition we'll talk about in the shoulder is AC joint arthritis. So the AC joint is a small joint at the end of the clavicle, and it starts to rotate as the shoulder elevates above 90 degrees. So there are shear forces going through the joint, and it's the only joint between the arm and the axial skeleton. The pathology of pain around the AC joint is that the joint itself is typically degenerative by about the age of 30. So AC joint arthritis can be considered a normal condition. It's often injured in sports, either by direct trauma, so falling on it, or by lifting weights. Classically, bench pressing, press up, shoulder presses will all tend to overload the joint. And predominantly this is an osteoarthritis, because it's basically degenerative change within the joint. The presentation, regardless of the actual underlying pathology, is the same as presentation in other arthritic joints. There's pain. In this case, very localized to the joint. Patients can typically point with one finger to the top of the clavicle and the joint. They classically have pain at the very top of range, so the 150 degrees up, and pain if it's loaded. So they describe that they can't do a press up anymore. The examination, again, there's never any wasting. There may be palpable osteophytes around the joint, and often patients will complain they've noticed a lump there, and it's often tender at the AC joint. The active range is usually almost normal, with this high painful arc, so said, from 150 degrees up to the end range, and the passive range is usually the same as the active range. There is a test for the AC joint, which is classically the O'Brien, sticking the hand straight out in front, turning the thumb down, pushing up when the examiner pushes down, and that should reproduce pain in the region of the joint, but like most shoulder examinations, it is a little bit unreliable. Like most things in the shoulder, the gold standard investigation is an X-ray, and you'll often see in narrowed space, you may see osteophytes and cysts and things. Again, if the diagnosis is uncertain, you can get an MRI, and this will show inflammation in the joint and the degenerative change with subchondral cysts. The conservative treatment is analgesia. As before, you modify activities, so stop the weights for a while, let it settle down, and you can undertake a steroid injection, which can be done either landmark based or ultrasound guided, which is often easier. And this will obviously not cure the arthritis, but may settle the symptoms down back to that which the normal population has. So all of these are possibilities, and they work most of the time. Ultimately, if the conservative treatment doesn't work, you can consider a surgical debridement of the end of the clavicle. This is very simple, done as a day case, and works very, very well. You need to know a little bit less about the elbow, and we'll talk about tennis elbow, golfer's elbows for the tendinitis, olecranon bursitis, and ulnar nerve compression. Moving on to the elbow, there are not too many conditions that you need to worry about. The first is tendinitis of either the medial or the lateral epicondyle. This is a medial lateral epicondylosis, or golfer's elbow on the medial side, or tennis elbow on the lateral side. The underlying pathology is degenerative change within the insertion of the tendon with a failure to repair, and this typically happens as a so-called disease of middle age, where there is degeneration, there's poor blood supply, there's overload of the adjacent tendon fibers, and then it becomes secondarily inflamed, and this is the tendinitis that people describe. The presentation is of pain over the epicondyle, either on the medial or the lateral side, with pain on active extension of the wrist on the lateral side, or flexion of the wrist on the medial side, and pain on repetitive activities, and this may be playing squash, typing, going to the gym. On the lateral side, as I said before, it's tennis elbow, and on the medial side, it's described as golfer's elbow. The examination is fairly typical now. There's usually nothing much to see. They will be tender over the epicondyle, and typically the elbow will have a full range of motion. The provocative testing is for the patient to straighten the elbow and cock the wrist, and if the examiner then tries to flex the wrist from that cocked back position, there will be pain over the lateral epicondyle, and if you reverse this with a flexed wrist and you try to extend it, they get pain on the medial side, medial epicondylosis. You can take an X-ray just to exclude arthritis, although you should have a pretty good idea that it's not there already. And an ultrasound will demonstrate the tendinitis or partial tears of the tendon. The vast majority of treatment for these conditions is conservative, with analgesia, rest, activity modification, so stop playing tennis or golf, whatever it is, for a while and allow it to settle down. And we know that this is a self-limiting condition. You can try these clasp braces that go around the forearm, and they certainly do settle some of the symptoms. Traditionally, a steroid injection has been done into the epicondyle, but the evidence suggests that these are actually worse at 1 year despite early good relief. More recently, people have been doing blood or platelet injections, but the jury's out on whether they actually work in the long term. Ultimately, if the symptoms really don't settle and the patient's fed up, you can do a surgical release of the tendon either on the medial or the lateral side. We need to make you aware of olecranon bursitis, as it's common, and you'll see this in your practice. So there are bursae in many locations between the skin and the bone on mobile surfaces. So you have them around the knees, around the elbow, and the bursa itself is lined with synovial tissue. A bursa can become inflamed. This is either due to recurrent irritation, so leaning on it, so-called student's elbow, direct trauma, such as coming off your bike and whacking it. You can get little bone spurs coming off the tendon around the elbow, and these can irritate. And after trauma, you can get little loose bodies of scar tissue in the bursa. All of these will irritate it. And when it gets irritated, the synovial tissue produces fluid and the bursa swells. There is also a possibility of infection. This is rare, but it does happen. The diagnosis is usually fairly simple, as there's swelling over the tip of the olecranon, and it may be warm. If it is red, or there's evidence of cellulitis, then it may be infected. And the bursa can be anything from very small to really quite large orange-sized condition, particularly if it's associated with some form of rheumatological condition. Sometimes you can even feel small loose bodies of scar tissue within the bursa itself. Investigations should include an X-ray just to exclude things like arthritis and bone spurs. And if you're worried about loose bodies or anything going on in the bursa, then you can get an ultrasound, but this isn't commonly done. So the treatment, like all things, is conservative before surgical. With analgesia, you can consider compressive wraps, activity modification, so if it's coming about as a consequence of leaning on it, then avoid this. You can try steroid injections, but they're not very effective. Ultimately, surgical excision of the olecranon bursa is required, particularly if they're very large or they keep coming back. Of note, if you have an olecranon bursa that looks like it's infected, then by all means aspirate to get a diagnosis, but resist the temptation to make a surgical incision, as these have a nasty habit of not healing, and then you have a real problem with an open wound. The last condition we'll talk about is ulnar nerve entrapment. So the ulnar nerve comes from C8T1 and runs behind the medial epicondyle. It supplies the small muscles of the hand and sensation over the ulnar border of the hand. It's usually fairly easily palpable. The nerve can become compressed at multiple sites around the elbow and classically between the two heads of the flexor carpi ulnaris. It's also possible for the nerve to become unstable so that it flicks around the medial epicondyle as the elbow is bent, and it can be damaged by direct trauma or even repetitive trauma, generating scar tissue in that region. The presentation is of symptoms related to compression of the nerve, which classically is numbness and tingling of the ulnar fingers of the hand, and if it gets more severe, interosseous weakness, wasting, and ultimately an ulnar claw hand if it's very bad. If the nerve is unstable, the patient may also complain of a painful clicking as they bend the elbow. The clinical examination, obviously inspection, you may see wasting, but this is quite a late sign. The range of motion in the elbow is usually normal, but they may well be able to identify a tender spot. A lot of the patients will have a positive Tinel sign at the site of entrapment, so if you tap on the nerve, you may reproduce symptoms down in the hand once you've found the point at which the nerve is compressed. The first investigation is an X-ray just to exclude any obvious bony abnormality, and an ultrasound may demonstrate compression. It also may confirm the diagnosis of an unstable nerve, if that's what you suspect. Ultimately, an EMG can identify both the location and the severity of the compression, and is a good indicator to the potential outcome if you were to operate on it. The conservative treatment, again, is activity modification if they're doing something that's particularly driving this. Splints can help, but people tend to find that having the elbow splinted in extension is uncomfortable. And physiotherapy may be of some advantage if there's tight areas that can be loosened. If the symptoms really don't settle and they're intrusive enough, then surgery is an option. And in its simplest form, this is decompression of the nerve at whatever point it's tight. And if the nerve is unstable, you can do a transposition to put it in its dislocated position. And this works very effectively at getting rid of the symptoms and stopping the nerve from snapping. That concludes the lecture on shoulder and elbow conditions for the MLA. I hope you found this useful, and please do look at the other lectures in the series. And good luck with the exams.